Yeah.
Right, good evening and welcome to the Woodlands, to what is the very first Dental Elf Campfire. This evening we are going to be discussing oral cancer, and we have a number of experts with us who are going to talk about oral cancer risk and prevention. So to save time, we'll introduce people as they start to speak. So first up is Professor David Conway. So let's pass you over to David.
Thanks, Derek. It's a pleasure to be part of this, and I look forward to a bit of debate and discussion today, covering, as Derek says, oral cancer risk and prevention. My areas of interest are dental public health and epidemiology. So trying to understand the risk for oral cancer, but obviously trying to do something about it and prevent it. I've got a few slides to kick things off, if I can start by sharing them with folks. If I can get the right button here. And here we are. So we are expecting a few people still to join us, but I'm going to kick things off with an overview. Al Ross is going to provide a human factors perspective. Can everyone see the slides?
Yep.
Yep. And then Simon Shepherd may join us to discuss the alcohol brief interventions in practice research that he's been involved with. Paul Brocklehurst, who's we're waiting to join the campfire, is going to discuss his research in Cochrane reviews and early detection, and Jan Clarkson kind of rounding things up and around how we can take this forward in terms of oral health assessment and guidelines and implementation, and we'll try and capture a debate. So good to kind of ask questions as we go along. I've got a number of questions for the participants that kind of follow from our slides, these slides, and we'll get some views from there. So as I said, going to try and capture this risk, reckon with risk here, and move into prevention and what we can do, mainly in a dental practice, primary care perspective, what we can do in terms of practice. This kicked off with a kind of blog type article I did for Scottish Dental magazine around trying to rethink and define how we communicate risk with patients, and obviously capturing the sea change in terms of the risk profile of oral cancer, particularly with regard to the role of HPV in oropharyngeal cancer, throat cancer. Also think it's quite good at the start of any kind of discussion on something like cancer and risks, and where we get into a lot of data discussion, to think of the patient and patients at the heart and centre of what we're thinking here. And this slide is from a West of Scotland cancer awareness project that we were involved with about 10 years ago, the WASCAP programme, where we tried to raise awareness of oral cancer as a disease. And we concluded from that project that it wasn't just about awareness, it was more about action and more about trying to better implement prevention and early screening in practice, and not just about awareness. So important to think about patients as we go forward from here. Also think it's quite useful for us to clarify what we're talking about by oral cancer and the definitions for oral cancer. So head and neck cancer is a broad definition which covers mouth, throat, larynx, so capture salivary gland tumours and nasopharynx, the nasal cavity tumours. What we're really focusing on here, though, is oral cancer defined as oral cavity cancer, and the majority of what we're going to be talking about here is about oral cavity mouth cancer, OCC, as opposed to oropharyngeal cancer and throat cancer. It's important to make this distinction because, as I said, HPV is part of one of the major drivers of oropharyngeal cancer, but has not much to do with oral cavity cancer risk, and I'll elaborate on that as we go. Obviously, this is an international and a global issue, and in fact, it's more prevalent in Southeast Asia than anywhere else in the globe. The majority of cases come from less developed, lower income countries, and even more inequality in terms of worse outcomes and high proportion of deaths. These are data from the World Cancer Report. And there's been a couple of quite substantial global analysis of the incidence and the burden of disease, and we see that HPV cancers have a greater burden overall in less developed countries, except however oropharyngeal cancer, so that's throat cancer, which is greater in more developed countries. So in general, oropharyngeal cancer is increasing, especially in high income countries, but oral cavity cancer is flatlining, perhaps decreasing in men globally, but increasing in women. So we've got this changing pattern of increasing oropharyngeal throat cancer and flatlining or slightly increasing oral cavity cancer. And this is more readily seen in this slide from English Cancer Registry by Louis et al., when you see that this is females here and males, and we're looking at age standardized incidence rates per 100,000 from 95 to 2015 and projected to 2025. And we can see the overall head and neck cancer is projected to increase in both men and women. And that is largely driven by the red line here, which is throat cancer, which is rapidly increasing, and in the UK, oral cavity cancer in green at a higher level and still increasing a bit. We see that similarly in Scottish Cancer Registry data, that the oropharyngeal cancer, throat cancer, is the most rapidly increasing cancer in Scotland, a 3-fold increase among men and a 2.5-fold increase among women. You can see that the increase, this is relative increases, relative rates, more rapidly increasing in oropharynx than in esophageal cancer, malignant melanoma, or cervical cancer. We can see that this is largely a cancer of older adults, and we can see an age distribution. It's very rare in under 45s, and the median age is about 65. Moving from that burden of disease picture to the risk profile of patients, and we can see the best source of data on risk factors in head and neck cancer is from the ENHANCE consortia, which I'm proud to be a member. And here's the membership in full from a meeting a few years ago, where we're really trying to pull together the global data on head and neck cancer. In the scheme of things, it's quite small volume, so any single study from, for example, where I'm based in Glasgow, we only have 100 or so case control pairs in our data set. When we pull that with European data, we have 2,500, but when we pull it globally, we can have 20+ thousand. That allows us to look at a number of different factors. There are a couple of papers, if you're particularly interested. The methods paper outlining what we're doing in terms of the meta-analysis approach in oral oncology, and more recently, a really nice overview of 10 years worth of data on risk factors, where we, in summary, pulled data on 35 studies from around the world, 25,500 cases, over 37,000 controls, mainly from North America, Europe, and some from South and Latin America, probably more limited from Southeast Asia, and that is certainly a deficit in our data and understanding of risk. So what have we tried to do? I mean, it's well known that smoking and alcohol are the key risk factors for oral cancer, head and neck cancer, and we've confirmed some of these estimates and given more precise estimates of the joint effects of smoking and alcohol, looked at this dose response, looked at the relationship with smokeless tobacco, and in relation to the benefits of quickening. I'm just going to summarize these data. There's quite a bit of data here, but we can, because confounding is always an issue in epidemiology, you can't really tease out which is the key risk factor. There's sufficient data to focus on the risk of smoking in those who never drink at all, so you're not got any issues with confounding of alcohol, and we can see a 2-fold increased risk for smoking in smokers for head and neck cancer. And similarly, alcohol in never smokers. You take tobacco out of the equation and you can see a similar 2-fold increased risk in alcohol among never smokers. The population attributable risk is also very interesting. We were able to tease that out, and tobacco and alcohol have that combined attributable risk, so they explain in effect 70%, 72% of all oral head and neck cancers. If we look at alcohol alone, it's a very small proportion, and tobacco alone, similarly, only about a third is explained, but you can see in combination it's another third, so you add these up in total and it's a 72% increased risk. And the dose response is interesting because we can see that fewer cigarettes per day over a longer period of time was worse than more cigarettes a day over a shorter period of time. So the duration was particularly important for smoking. That's similar to the picture we see in lung cancer, where duration is more important than frequency. Alcohol, however, was a higher intake over a shorter time, was worse in terms of cancer risk than a lower intake over a shorter time. But it's not quite everything in moderation. We see that smoking is a greater risk factor in larynx. Alcohol is a greater risk factor for oral cavity and pharynx, and everything in moderation refers to there wasn't a safe low limit. So low dose smoking, low dose alcohol also conferred an increased risk. Smokeless tobacco, not necessarily the preventive measure one might try and shift, or the tobacco companies might be interested in shifting us towards. There was an increased risk for oral cavity cancer, a threefold for snuff and nearly twofold for tobacco chewing in the enhanced data. And the benefits of quitting were actually really quite clear. There was an immediate benefit in 1 to 4 years after stopping smoking, and the risks associated with the risks equated with never smokers after 20 years post cessation. So it did come back to previous low risk levels of never smokers. However, that alcohol risk after cessation of heavy alcohol consumption only emerged after a more prolonged period, so that the effects kind of lasted longer. The socioeconomic perspective is also really important, and we found in this detailed analysis a 2.5-fold increased risk associated with low education and low income, which was not explained entirely by smoking alcohol. So there's a third of the risk associated with low socioeconomic status remained and wasn't explained by other risk factors as far as we could tell in the data set. And there was no difference by sub-site, and greater where there was greater inequality in the countries. So from that we move into the area of HPV, which, as I said, is more a factor in oropharyngeal throat cancer than oral cavity cancer, and hence why we have to really look at these separately. It's understood as a necessary cause of cervical cancer, and it's the same HPV oncogenic types, 16 and 18, which are the largely implicated in this. Perhaps causes 25% or associated with 25% of all head and neck cancers, but almost the majority, 80% of oropharyngeal throat cancers. But we really don't understand very much about the prevalence, the incidence, persistence, the determinants of the oral HPV infection in itself. However, it's likely to be sexually transmitted, and our data from where there are sexual history data within ENHANCE shows that large number of lifetime sexual partners, a greater number of sexual life partners, oral sex partners increase the risk, as does early sexual debut. And we're just starting to look at studies have only more recently started to look at the focused on the risk of HPV and head and neck cancer, and see that it is very much focused on oropharyngeal cancer, with, you can see, quite high odds ratios in the kind of landmark New England Journal study. We have also identified within our subsample of enhanced data the E6 antibodies appearing ahead of, and it's been confirmed in a cohort study, that it appears perhaps up to about 6 years ahead of oropharyngeal cancer emerging. So we can see that there's something about perhaps the persistence or the duration of oral HPV infection that is likely to be that risk factor. So moving on, just to summarize all that into a kind of risk profile or a stratification of patients, and we'll see that it's largely older men. It's perhaps slightly younger for oropharyngeal cancer, but not hugely younger, maybe 65 is the mean age. It's, males greater than females, largely from poorer socioeconomic circumstances and backgrounds. Smoking alcohol remain the dominant risk factors, and we have to capture, although there aren't really any ways of measuring that readily at the moment, oral HPV, particularly, as I said, for throat cancer. So as Clemenson said, the founder of the Danish Cancer Registry, the aim of every epidemiology study is to prevent it, and that is what we are trying to move and shift our thinking into. Okay, we're now got a clearer picture of some of the risks, particularly in relation to oral cavity cancer. How can we readily prevent that in terms of practice and potentially policies? Now, there's two broad different prevention approaches, and I think if it is HPV-driven cancers, we've got the almost unique benefit of the HPV vaccination program, and in some ways that is for, I think, for another campfire to discuss HPV-driven cancers. What we want to focus today really is on non-HPV-driven cancers, and Richard Watt's work in terms of prevention and practice and preventive principles are good to draw on in that, and kind of summarise them here and try to apply them into our thinking on the risks of oral cancer. And on one level, age is not an issue in terms of the risk factors. So when you look at a sub-sample of, when you look at risk even in younger adults, say 40s, 50s or under 65s, it's the same risk factor profile. It's still largely dominated by smoking and alcohol. This is oral cavity cancer we're talking about here. And so the risk factors remain the same irrespective of age. We see quite clearly that risk reduces when you stop behaviour, so there's something potentially in a teachable moment there. We also have in dental practice setting an opportunity to do an oral health assessment, perhaps a robust assessment, and tying that into the risk factor assessment is obviously potentially crucial. And then we can deal with some of these risk factors in terms of referral, signposting, or even potentially brief interventions or interventions in practice, either by the dentist or the dental team. And it's important also to recognise that advice perhaps needs to be tailored perhaps to the oral cancer risk, but also to the socioeconomic circumstances and the perspective of where the patient's at in their change journey. I will finish this talk really with some questions, I think, for the panel to consider as they kind of deliberate a little bit, and for us to debate a little bit more, is around prevention and early detection in practice as well, which is what is the evidence for prevention in practice? There is perhaps some evidence of the effectiveness and cost effectiveness of opportunistic screening. I would like to kind of debate how that can be more readily implemented. But what questions I think still remain in this area around what constitutes an evidence-based preventive early detection intervention? Can the role of risk assessment and profiling assist? And we start to profile it based on these enhanced data, as I've mentioned, on age, gender, smoking alcohol, and socioeconomic status. Given that this disease is such a low volume, is early detection a realistic possibility? If it's so rare, are practitioners going to see it when they're not tuning in to seeing it readily? Is there a skills issue associated with that? There are also inequalities in access and uptake to opportunity. If it's in dental practices, are proportions of the population who are most at risk potentially not being seen in dental practices or other aspects of primary care more readily? And what are these other barriers and facilitators to screening? So having thrown all these questions out, I'll kind of put you on the spot here, Al, to reflect on that and almost to think about a human factors perspective and how what that can bring to thinking about implementing prevention and early detection practice into the primary care setting, and what are the likely major barriers and facilitators to implementation. Al, could you start as we're doing with an introduction of yourself and your background? That would be great. Thanks.
You need to unmute your microphone, Al.
Al, are you there?
Hello,
Hello, I can hear you.
can you hear me now?
I can hear you.
Yes, we can hear you.
I'm sorry about that. Yes,
No,
well,
it's fine.
Okay, I heard you loud and clear, David, so thank you very much for that. And okay, my name's Al Ross, and I'm a lecturer in behavioural science at Glasgow Dental School. I'm one of the teaching leads for patient management and health promotion, and where I come together with David is principally where we co-supervise 2 PhDs in this area around the oral examination and the preventive advice in relation to oral cancer. I would like to start really by saying that this has to be understood, translated and acted upon by dental health professionals. And for preventive activity, information has to be gathered from and communicated to patients. And all this has to take place in busy, pressured working environments, perhaps more aligned to treatment than prevention, to achieve the outcomes that we are interested in. All of which is to say that while my background is in psychology, so I may not be a dentist, I would say that you are all, in practice and in public health, as dental practitioners, if you're interested in this area, you're all basically behavioural scientists and psychologists. I don't mean to start off this conversation in a provocative manner. I know we might hear also shortly from someone who I think qualifies in specifically in both camps. So I'm going to make a pitch, really. The other people that will follow speak with some authority, as David has around oral cancer. I'm making a kind of sort of Dragon's Den pitch here, I think, for the utility of human factors as a scientific discipline, as I suppose one resource that dentists and others interested in these areas can draw from in a multidisciplinary type approach to prevention. I have this little logo here. Here for my offline slides from the Human Factors and Ergonomics Society. That's the chartered body, and I can say with some authority that Human Factors is coming to a regulatory body near you sometime soon. This concordat was recently signed by a very wide array of professional bodies: the General Medical Council, the Nursing and Midwifery Council, Public Health England down south, and the CQC, NICE. And also in Scotland there are similar documents endorsed by NHS Education Scotland and Healthcare Improvement Scotland, all saying that human factors as a science offers a sort of integrated way to look at improvement in health outcomes through looking at health services and looking at behaviour of patients and so on. Last time I mentioned the GMC, but their new public consultation, which I've had sight on what they call generic attributes, generic professional capabilities, medical professionals, specifically has a whole section on human factors and ergonomics, and very much has an orientation towards patient safety. So, and things like misdiagnosis, for example, would come under that rubric. So this is now gaining traction, and I'm just going to try and sell it, I suppose, in this context, and come back to the oral cancer in a little minute. So the way I'll do so is to really outline 2 systems. Let's think of 2 systems. First system is a jet engine. This system is complicated. Not many people know how to build one, but however, how to build one is known. The parts that are involved have specifications, and the configurations are tested And if you put the right parts together in the right configurations, you will get fairly reliable output. You can produce what some people will remember in terms of motoring, a sort of Haynes manual as to how to put together these things. And with a bit of training and a bit of understanding, you can follow the rule book, if you like, the algorithm, and get to the outcomes that you want. The order of parts is known. We know what's necessary, what's sufficient, and we have these rather sort of linear kind of cause and effect things that help us as we design and build these things. We often treat healthcare, let's take prevention in dental practice, as if it's a bit like that, as if we can isolate particular components that are wrong or broken, fix them, put them back together again, and then everything will run smoothly. But let me just contrast the jet engine system with another system. And I'll just use the example of another system, which is bringing up a child. Here, the rules, the configurations, the specifications, the interactions, how all the component parts fit together to produce the outcomes that we desire are pretty much unknown, and I might argue unknowable. So the output from the system, your sort of functioning young adult, emerges in ways that are not linear. The same output can arise from different systems, or you can get different output from almost identical inputs and so on. And I would say that evidence for the fact that there's no particular manual for bringing up a child is that there are hundreds of manuals, and none of which seem any better than the one before. Basically, any system with people in it, including dental professionals as people, which seems wise, is complex. The jet engine is complicated, but this system is complex. And in complex systems, things change function. Propeller never becomes a valve, but people change their goals, their orientations, their knowledge changes, their motivation changes. Unlike all these parts in the technical systems, like compressors and combustors and so on, pumps don't become ignitions after going on a CPD course. People change all the time. People used to write diaries and get really annoyed if you read them. Yeah, nowadays people write everything on Facebook and get really annoyed if you don't read about their personal lives. Things change, and so the job of human factors really is to specify, if you like, all these mechanisms, is to try and understand how all these things fit together and try and work out in a work system the interactions, the dynamic changes that give rise to the outcomes at any sort of broad moment in time. So I'll flash up, just as I get to finish, like a model of prevention in practice. This one's for dental caries. You can sort of, it's not my intention that you can read it, but you can see how we have modeled here over about the last year or so all the different things that go into this particular system, and how they fit together. What is a precondition for what seems to affect other parts of the system. And there are a whole number of areas that impact upon each other in different orders, as well as in different configurations, in order to produce these preventive sort of behaviours in the professionals and outcomes for patients that we want. And I'll just finish like Bob Dylan. I've just got my sort of my slides here. We have dental teams, professionals working, and we have the skill mix there in terms of who performs particular activities. We have whole ways of, like, of course, incentivizing, and we have, I'm reading this back to front. Yes, we have to monitor and regulate, and these systems impact upon behaviors. Our patients come with needs. They come with all sorts of like issues that we have to take account of. Here we go. We have, I think it's often assumed, this is perhaps the most important point, I'm assuming we're going to hear more about this as we go on. This is really is only just one part of the system, producing really good evidence and guidance that has a good nod towards implementation. And then we have all sorts of ways we record activity. We can use our IT systems to document activity in ways that can help us out. We have other equipment and technology, of course, in dental practice, and various tools and techniques for oral screening and so on. And lastly, very importantly, this last slide's a bit like Pink Floyd album cover or something. We have time and space. We have to look at where this activity takes place, when it takes place. No one seems particularly interested in whether advice on alcohol consumption, for example, might be better received on a Monday morning than a Friday afternoon, but all these things are important. And so the human factors arena is broad. We do engage in what we would call work systems analyses, where we look at the boundaries between all these subsystems, where they clash, where people have to make priority decisions, and how they interact for any given purpose and outcome that we're trying to achieve. We have to try and specify, like I say, to go back to the idea of the engine, what works best in what order, and what works reliably and what doesn't, and so on, so that we design in our preventive activity. It can't just be shoehorned in or imposed. It must be designed into the system, which is where I think I should pause and hand on to the next person who's going to speak, who I think might be Paul.
Great, thanks very much, Al. Everybody has their microphones muted at the moment, so you'll all need to unmute by putting your mouse on the video screen and clicking on the microphone button.
Thanks, Al. I wonder if I can just ask you a question for you to ponder, and we'll come back to the end. And it maybe preempts your research, but do you think do you get a feel for any of these factors that are more important in terms of implementing guidance in this area, or does it all matter? So it's maybe, of all these kind of final slides you were throwing up there, does it all matter, or there are more? Have you got a hypothesis about which are particularly more important? I think, yeah, go on, Derek.
David, I was just going to come in there and ask perhaps Jan to also think about that, because of the work that she's done in relation to oral health assessment and the barriers that they identified, because two of the questions we wanted people to ask were about smoking and alcohol, and they came up with some interesting findings from that work. But I think Simon unfortunately hasn't been able to join us, who is going to talk about that activity within the practice setting itself, and I think would have given us some useful insight. But I think we'll probably go over to Paul now and listen to his work about the screening, and he might like to say something about skill mix as well, because I know it's an area of interest for him.
Sure. Can everyone hear me? Am I coming through okay? Okay, so I've got a 5-minute brief slot to talk a bit about the evidence, and I'm going to be breaking that down into two main elements. One which relates to a Cochrane review which I led, looking at effectively the question is how effective is at reducing mortality rates. And then the second part of the presentation will really be looking at the evidence that we've gleaned, which is quite interesting, looking at the relative performance of the dental team at examining oral cancer, and how well they can differentiate positive lesions from negative or benign lesions. Slightly different from a screening question, that latter one is, because obviously we're looking then to differentiate between two different types of lesion. But we'll come on back to that shortly. I'm not sure if I've got any reference to any sort of slides, so I'm just going to sort of crack on and basically do this orally. The Cochrane review on looking at the effectiveness of oral cancer screening is quite an interesting one, because effectively, and really sort of picking up on Al's point here about the evidence, is actually quite a difficulty here in terms of, and also what David was saying earlier, in terms of the availability of good quality evidence, because of the relatively low incidence of the disease, even in sort of like developing countries where the incidence is much higher than developed countries. So it's quite tricky then to actually work out getting that evidence and which bits of that evidence are actually relevant to how we practice in the UK. So I'm going to go through the Cochrane review, and then that will sort of throw up some quite interesting things. So there's only one study done over 15 years. It's a cluster randomized controlled trial. So obviously entry criteria for a Cochrane review is that it has to be an experimental design for this type of question anyway. And out of 3,239 studies and many more that were screened, we only came up with one. And say this report's over a 15-year period, so would think to actually be quite good evidence. They randomized, say, cluster randomized trial, cluster randomization at the level of districts. So this is in Kerala in India, and they have about 13 districts, 7 which were allocated to the test group, 6 that are allocated to the control group. And they, in terms of numbers of participants, they randomized 191,000 people into those 2 groups. And in the test group, so the ones that actually received a screening, those people received a screening from an allied health professional. So the screening technology applied to all the participants was not initially by a dentist or by a doctor, but someone who had some training. But many of these were sort of like graduates rather than actual clinical people with a lot of clinical experience. So they had their training. And the principal outcome measure for this particular sort of study was mortality rate. And what was interesting in terms of the mortality rates for the screen group compared to the control group was that there was no statistical significant difference at the population level between those that underwent a screening program and those that didn't undergo a screening program. So in terms of the number of fatalities, there was 15.4 per 100,000 in the screened group and 17.1 per 100,000 in the control group. So that wasn't significant. What was interesting, however, was that when the subgroup analysis was done on just high-risk groups, so this was so the previous figures related to everybody. This related to those that were smokers or drinkers or both. And what we did find there is that there was a significant reduction in the mortality rate per 100,000. So this time we had a mortality rate of 30.0 as opposed to 39 in the non-screened group. And what we also saw, and this was significant as well, was that there was a stage shift. So there was much more numbers of class 3 and class 4 stage disease in the non-screen group compared to those that had actually received the screening program. Now, there's all sorts of issues with the evidence here in terms of how people were randomized, how they were concealed from that randomization, the pathway from being screened positively to then going on to see a dentist, to then going on to see secondary care. Not all were biopsied that were along that sort of pathway. So there's all sorts of quality issues and risk of bias issues that are related to this study. And this is kind of beset some of the evidence that's come out of this. But the overarching sort of message, if you're looking at the outcomes, is that there doesn't seem to be any real difference at a population level across all groups. But with high-risk groups, we do seem to be seeing a change in mortality rates. And we also do seem to be seeing a stage shift, i.e. catching the disease early in the screened group. So that is quite an interesting group of studies to look at, but publishing across 4 papers. And they've also done a cost-effectiveness study on this, where they've looked at how cost-effective doing screening would be. Again, a high-risk strategy appears to be quite positive compared to an all-population approach. The trick then is trying to think how that evidence actually relates back to a UK population, where the incidence is much lower, although there obviously are pockets of increasingly so pockets of obviously a large multiculturalism, and therefore with that bring an awful lot of habits which are known to be associated with oral cancer, like pan chewing and reverse smoking, etc., etc. In addition, just general use of tobacco. But how we apply that evidence is actually quite intriguing in terms of then how we do that in a developed world where the incidence is much less. And I think one of the other key things here that it may be worth thinking about, and also raises the question about sort of more role substitution and questioning where we do some of these strategies, is that certainly the evidence I've sort of seen, the risk factors associated with oral cancer are more likely to be linked to those people who don't attend practice. Now, it's not totally exclusive. A lot of people still do attend with all the risk factors. But if you were to sort of like do a sort of very gross calculation based on those that don't attend and those that attend, those that don't attend tend to have more of the risk factors than those that do attend practice. Doesn't mean to say that we shouldn't be doing this or that there isn't real opportunities, but that I think is something else which might be worth considering. I don't want to. I'm just aware of sort of time. So,
do you mind if I just ask a question on that evidence, sure. Paul? So I was well aware of the Kerala study for quite a while, and I hadn't really tuned into it until I read the Cochrane review, because I was thinking this is high-risk population, as you described, and high-volume disease, most common cancer in that part of the world, or among the most common cancer, quite a different profile. But interestingly, as you rightly described, it wasn't in the population where the detection and screening was beneficial. It was in the high-risk groups.
Yeah.
Now, I was quite curious when you then concluded, however, and perhaps I'm just wondering what in the Cochrane review that there wasn't a conclusion, or maybe the evidence wasn't necessarily strong enough to support a more stratified or focused screening, and you were going into other reasons why that population might not be the dentist, but almost the conclusion in the Cochrane review was you need to do a routine thorough clinical oral examination on all patients. But the evidence is suggesting actually no, that more focused attention, and if it is about time and cost effectiveness, does it have to be in a more stratified group or section of the population? So I'm just wondering what you think of that. It'd be good I know you're going to go into I don't know whether it's more the skill mix part, but maybe if you could have think of that.
Thanks, David. I think one of the issues here is obviously being mindful of Cochrane and its influence, and I think the emphasis should be on this is an important thing still to do. However, I think if you were to sort of take the evidence base as at a population level, at a dental public health level, if you like, rather than actually at a practice level, and looking at it, should we actually engage a screening sort of program based on this evidence? I think the evidence is difficult to properly decipher, because there is certain evidence to suggest a stage shift and also a reduction of mortality rates, but the quality of this evidence is really quite poor. So I think this has always been the beguiling element of the Kerala sort of study, is that it offers something, but equally the quality of the evidence so it's trying to interpret both of those together. And I think the next one will be interesting with the use of the grade as well.
And not so much the screening program, but more the opportunistic screening that you're mentioning. You even shaping the opportunity or the opportunistic screening, or targeting that a bit more within our patients that attend practice. Is that a goer, or is it more a medical legal sense that, oh, you don't want to miss it in a 20-year-old healthy person who doesn't have risk factors, therefore, I'm not saying we shouldn't be doing thorough clinical examinations or basic examinations in all patients, but I'm just wondering whether there should be a bit more attention or more frequent recall that touches on some of Jan's work around recall interval. Is there something that is more, we should be doing more when we're thinking of bringing the risk profiling of stratification into this detection?
I think there is. I think that we have to be a bit careful in terms of these questions. They are quite different in terms of one is obviously a population sort of screening question, and one is actually what's relevant for practice. And there is always going to be a little bit of overlap, given the fact that the readership of the Cochrane Review is going to be quite broad. And so there is always an element there where you're sort of appealing to sort of a number of different audiences.
Sure.
But personally, I think a regular sort of screen is what you should be doing, and from a medical legal point of view, and certainly this evidence from the Corona study would suggest that high risk groups in your practice population are people certainly to be very vigilant over and have a higher index of suspicion.
Okay, that's the key. So is it, how do we do that, or does that shape the guidelines? I think, how do you ramp up that index of suspicion? Or do you do anything differently? Is it a bit like cross-infection practices, same for everyone, or is it more focused?
I think part of another very beguiling aspect of oral cancer research is because of its relatively low incidence, particularly in the developed world. It's actually quite difficult to plan and even to get good studies funded because of the fact that oral cancer relative to other cancers is not as common, and so the big funding bodies will be more mindful about relative value for money on oral cancer compared to, say, bowel cancer. But there are some very interesting questions which have kind of like remained sort of in a sense of sort of aspect really in many ways, because Paul Spate did quite a bit of work looking at sort of developing algorithms and computer-assisted sort of learning to actually look at ways we can identify sort of risks through smoking and alcohol particularly. But that was always based on, and where it stopped, the HTA report, which came out back I think in 2006, was still based on assumptions about some of the parameters which we use to populate the model. And we can't get past that because of the fact that it's quite difficult to get the evidence to populate those sort of models. So I think the agenda certainly can be moved on. I think it's actually probably having to be quite creative in thinking of ways which we can move that agenda on, which make it appealing to sort of funding sort of bodies and answer some of these sort of broader questions. As a dentist, as a sort of public health person as well, I would sort of say that opportunistic sort of screening is absolutely essential and should form part of any oral health assessment. Shall I jump me to finish off? I'll try and be fairly brief for the last bit, and then I can then shut up. So what was this last study really was a study which we did published last year, where we looked at how good different members of the dental team are at differentiating between malignant and benign disease. So it's not a screening question, and we did that deliberately because if you had a screening test, you'd basically be having a positive lesion in amongst lots and lots of health. And because of the relative incidence of the positive lesion, you'd have to have thousands upon thousands of photographs or study. You'd have to design your study quite differently. So we were looking at how different members of the team could differentiate between benign lesions or potentially benign lesions. So, malignant lesions or potentially malignant disorders, beg your pardon, and negative benign lesions. So we were very careful how we sort of set all that up. We did it using photographs from Mike Lose in Cardiff, and we distributed those photographs according to the relative incidence of those lesions in practice based on LIMS study in 2003. And that was a inner city London sort of study which looked at basic prevalence of benign and positive lesions across in inner city dental practices, and we found some quite interesting results. So we asked three broad groups: hospital-based dentists, dentists working in primary care, so that was predominantly general dental practitioners, but also included some salaried community dental service practitioners. And we also looked at hygiene therapists as a third group. Sensitivity, so that's the ability to identify disease, if disease is there to be identified, was 90% for the hospital-based dentists and 77% specificity. So that was the ability to detect health if health is there. So that was 90% and 77%. Dentists in primary care scored 77% and 71% respectively. So they were able to identify 77% of the lesions that represented positive lesions, malignancy and potentially malignant disorders, and they were able to identify 71% of those that were benign. The interesting thing then was how that compared to hygiene therapists. And this came at a time when direct access was a big thing, and there was a lot of kickback from the BDA about safety of hygiene therapists. So we're quite interested at the comparative performance, if you like, between dentists in primary care and hygiene therapists. And what we found was actually very little difference between the two primary care practitioners. So remember, 77% sensitivity and 71% specificity for dentists. For hygiene therapists, it was 75% sensitivity and 68% specificity. Now, one of the things that if you're in a diagnostic decision, you tend to find that judgment favours, if you're uncertain, you tend to favour being safe. So what that does in a judgment decision when you're looking at sensitivity specificity results, actually what you find is that if you were to effectively score all lesions as positive, so you'd be totally safe because you're making no different comment on the lesions before you, you'd get 100%. Sensitivity, what you would get is a drop in specificity. So it's that balance between those two, which is always really, really important, really quite interesting. What we saw, both in the point estimates, so they were obviously the point estimates, but also in the spread of the individual points in rock space, so that's how we plot sensitivity and specificity together, is that both the point estimates and the spread, or the variance around those point estimates, was actually really, really quite similar with those two groups. And actually, when you looked at the number of frank malignancies that were missed, there were a lot fewer frank malignancies missed by hygiene therapists, and fewer. And if you looked at the number of frank malignancies missed in terms of numbers, if those that missed one, again, there was more dentists that missed one compared to hygiene therapists, and missed two compared to hygiene therapists. So there's a picture here of effectively, I don't want to make too much of this, but there's a picture here of relative equivalence. And it's also quite interesting how it then ties back to that screening question, because obviously, again, one of the things there that often people don't pick up on is that the principal health technology that was being tested was allied health professionals, not doctors, not dentists. That was the next stage on that people got referred on to. So I do think, again, coming back to Al's point that they put up in terms of role substitution skill mix, I do think this is one area for me which is quite interesting in terms of how we might want to expand what we do and the kind of people that we use. So I don't want to go on too much. I'm aware that I may have gone on a bit, probably double my time, but so I'm going to stop there. I'm happy to take any sort of questions or chat, chip into bits as we go on.
Jan, do you want to say something about the barriers and some of the things that you've found from your work with the oral health assessment?
Yes, I suppose my role in Scotland is to work with a team to produce guidance for dentistry. And as David mentioned, one of the topics was to consider evidence and develop guidance for an oral health assessment. And I think, David, you posed what is evidence-based practice in terms of prevention. And I think the discussion has clearly demonstrated that there are risk factors, such as smoking and alcohol intake, that presumably, if the patients changed behaviour, their risk would be reduced. There's also the issue of taking an examination to identify earlier pre-malignant lesions, which would have then an impact for patients. And as Al very articulately demonstrated, dental practices are very complex systems. But essentially what we're talking about are relatively simple dentist behaviours in terms of taking a medical history and an oral examination. The challenge is, what do dentists do once they've elicited the knowledge from the patients? And I think, David, you mentioned you've got two options. Well, there are three options. You can do nothing about it. You could signpost a patient to go and seek advice, or you could, as a dentist or a health professional within a dental practice, give a brief intervention. And this is where I think the real complexity lies, is knowing what best should be done in practice. So the first premise would be, you have got to have the information in order to make a decision, and that requires patients to give it to you. So the work that we did to help inform the guidance that we developed, but essentially its implementation, and as Al again mentioned, producing guidance, it was thought that that would be the magic bullet. It clearly is not. At best, behaviour may change 7 to 10%, and that is if it's good guidance. So we know we have to do other things. And as Al mentioned, that could be around systems of IT as much as it could be within the regulation and funding of a dentist and dental services. So we looked at what dentists did, and we have an audit that involved a third of dentists in Scotland, so that's 1,000 dentists. They provided information on 10, and detailed information on 10 of their adult patients. So we've got information on 10,000 adults who are attending dental practice in Scotland. And what we found in terms of dentists asking information about smoking behaviour, then routinely around 65% of dentists would do that. So 2/3 of dentists would ask that. Only 5% asked no one, but the remainder, it was inconsistent. But it's very different when you look at alcohol information. And actually only 1/3 of dentists would routinely ask information about alcohol intake. And actually almost half would never ask that question. When you start probing into the reasons for that, it includes issues of being concerned that patients do not want to share that information with dentists. And in fact, if they did share it, they would maybe not be honest about what that behaviour is. So we then go to the patients, and we have spoken now to 100 patients about what they expect and anticipate from dental practitioners. Now, when asked whether or not you would provide information about alcohol intake, diet, smoking, and other lifestyle behaviours, all patients would say that they would give that information if asked. And actually, I think what you might be surprised at is that they would expect dentists to be asking that information because they see that there is relevance to their oral health. But the surprising factor maybe is that almost 60% believe that dentists should be giving them some advice about smoking, and over half, just over half, about alcohol. So we've got a sort of like contrast between what dentists are maybe imagining that patients are expecting and what patients would expect from their dentist. In terms of oral examination and the head and neck examination, We know that dentists, despite it being part of training and curriculum in undergraduate training, there is issues of their confidence and competency. And so obviously we have got some training issues to do. And I'd say that in terms of the history taking, there are easy tools that could be implemented within practice systems to make this a habit, as other aspects of history taking are, such as medical histories. So from our work, we believe that easily things could change. And I know that the work of Simon Shepherd has gone further in understanding what tools could be implemented to change the behaviour of dentists. And essentially we've got to make decisions too around whether or not it is best for dentists to signpost or to deliver brief interventions. And in terms of sort of like the public health research agenda, making every contact count in the health service, then irrespective of age, I do believe these are behaviours and acts that should be conducted as routine in dental practice, because of course these habits not only are predictive of oral cancer but other issues of ill health. So I try to be brief, and I hope that has helped with the debate.
Thanks, Jan. I've got a couple of points from Simon, who's been having difficulties listening, but he can't join with us, unfortunately. He said one of the key things that seems to come out from his research was that oral cancer alone can't just be the dependent factor for dentists getting involved in delivering health risk advice. And secondly, relates to the fact about dentists' belief of what their perception of their position, and that they are perceived as just dentists and not healthcare professionals. You know, sort of, and I think that's a big issue, because dentists are highly trained health professionals and who do a 5-year plus degree course, and they're quite not perceived as within the general healthcare professions by some groups within the profession. Certainly it's the way they feel. Certainly that's what came across in Simon's research.
I wonder if I could just come back a little bit on what Simon's saying there. I mean, I think I agree with him, not alone, but I think it is a pretty big hook for dentists to get to grips with, a good justification for dentists asking these questions and dealing with it, particularly around alcohol. Smoking obviously has common risks with other dental periodontal disease as well. I also note recent kind of statements from the General Dental Council where there's an expectation of dentists providing smoking cessation or doing something, whether it's actually directly providing it or signposting it, as Jan says, doing the brief interventions or referring. I think we have to work out what is the best evidence for dentists, and I know Al's involved in trying to review some of that literature at the moment. But I think we can maybe bring oral cancer as a big hook for getting practitioners involved in generic prevention work. And it also maybe, and it's back to Paul on this one, is oral cancer the hook to genuinely implement the clinical oral examination, or more thorough clinical oral examination, more explicitly saying this is an oral cancer check. I know there was an article in the BDJ trying to make the point there. But is that something we can bring into both that prevention and early detection kind of thinking for practitioners?
If while Jan's thinking, can I jump in there? Because I mean, I think potentially it is, but I mean, it goes back to some of the human factors that Al was talking about earlier. It's about the structure and the way in which dental practices, the models in which they exist at the moment. I think they for years they've been treatment focused, and we've been trying for years to make them do more prevention by a number of means, and I don't think we've succeeded. So it's about and skill mix has a role here, because I think team working in dentistry has never really taken off, and there are structural issues there. And I think all of these influence the way dental practices are perceived by the public as somewhere to go to have your teeth fixed. They're not perceived as, in general, healthcare establishments, and I think that's part of changing that, in that the way that dentists and we think about dentists is important if we're going to move things forward. If we can get some practices work like that, but they're in the minority, a small minority.
What's very interesting, the issue of whether dentists should be giving brief interventions. I think a team in London put in for funding from the National Institute of Health Research for that study, and it was rejected on the basis that that evidence is known. And so, you know, within dentists, it's quite interesting and challenging, considering, you know, I mean, whilst we would want to implement things based on evidence, and the question is whether or not it is transferable, the evidence of brief interventions to dental practice, I don't think we're going to get funding to actually elicit that. I think what there will be are opportunities. There is likely that there are going to be changes to maybe funding models, and whether in England it's through the commissioning groups, and in Scotland. And I anticipate that there is going to be almost sort of like regulatory issues around eliciting a more comprehensive oral health assessment that will include history and examination. So I think there are going to be political measures and pushes for change as well. But to emphasize that whilst people may believe that it's a lack of money for dentist time, certainly if that is the only thing to change, there will not be a change in the behaviour within dental practices, because money doesn't mean people do it.
Jan, can I come back on a specific question in relation to your research on recall interval in dental practice settings? Does the risk profile in terms of smoking alcohol risk, in terms of potentially malignant disorders that are detected, how much, where are we in terms of that influencing recall interval? I know that the NICE recall guidelines suggested dentists make a judgment based on that. Your research bringing that into that in your recall interval research? Or I'm just wondering where you're at with that.
Certainly from the research that we're doing on that, dentists are making judgments around risk factors for oral cancer in determining the recall interval. And we know that changes over time should factors change for patients. So yes, dentists are responsive to that.
We've lost Eric. He's dropped offline. I wonder whether we could just, and we're 10 minutes over, I wonder if we could go round the campfire to finish, and people's kind of give us some final thoughts on what they've heard and where we think we may have to go in terms of a research and policy agenda in this area. I'll maybe start with you on this, and then Paul, and then Jan.
Thanks, David. Well, can you hear me? Yes.
Yep.
Yeah. Just a couple of things, really, just picking up on, you know, I listen with fascination to other people speaking, and, you know, as an enthusiast almost, as a sort of outsider, if you like, and there's lots of things that resonate, but just a couple of things. And this is another human factors book by a friend of mine called Eric Holnagel. It's called The Efficiency Thoroughness Trade-Off, and it relates to what Jan says about money not being the thing. The thing is actually culture, and I have lots of evidence from talking to dentists that they're really operating under a sort of fear of failure at the moment. And so they will say that the NHS, and I quote, the NHS primary care contract has all the risks loaded on the practitioner side. There's a lot of threat of referral to the GDC, outdated payment systems that don't match first world dentistry. And someone here, the whole culture is changing. We are practicing defensive dentistry. Now, I think prevention and advice is aspirational dentistry, as public health is aspirational. But if people are, have to choose between a brief intervention that might not be that brief, that requires them to do some training or to operate slightly outside their comfort zone, or simply to refer, then the referral is quicker, safer, and will be the sort of preferred option where these priority decisions have to be made in a system that I think is quite stressed. And David, you asked me, last thing I'll say at the beginning, the main barriers and facilitators, I do get the feeling, again, about this thing about you can't just keep loading in targets and aspirations and things that we want people to do, where the feeling is that they are overworked, overregulated, and, like I say, practicing it sort of right up to the limit. And so we have to think about how to make it easy is the simple sort of aim. It's not simple to do, but it does require probably a thought about sort of what priorities will have to go. If we want this to be a priority, something else has to give as the sort of like systems view, and we have to think where we can fit this into the context. But it does seem it's not a crisis, but I get a lot of feeling that this is a stressed system where people are working quite hard to make ends meet, and the stress levels are quite high. And so simply saying we would like this in an ideal world, then we'll just come back with the answer, well, this is not an ideal world,
Great, cheers out. Paul, final thoughts?
Yeah, I mean, I think probably more than ever our profession is in a bit of a state of flux. I think we've come from a position where we've had a lot of disease across that whole of the age range, and we're seeing quite marked sort of shifts in both demographics and in the distribution of diseases within sort of youngsters, but also particularly I'm thinking about older people as well, and in a range of stratification of risk in the adult population as well, with a lot of people who actually really are quite well, and others which still have, still having transient disease. So I do think actually, for me, dentistry is reaching quite an interesting position, which is why I think you're sort of seeing a lot more different types of remuneration systems being tested. I'm leading on evaluation of a capitation system in Northern Ireland, and they're going to be returning back to fee-for-service in the next sort of 3 to 6 months. And it's interesting the response of the GPs, the GDPs, in doing so. They've had now sort of 6 months or so working within a capitation system, and they've begun to learn to really enjoy the freedom that brings. Whatever we think about remuneration sort of system, I think there's an overarching need to move from a cure culture to a care culture. But I do think there is still this area of stratification. I do think we're getting increasing sort of pockets of health and still in transient disease. So I think rather than a one-size-fits-all, which I think we've been able to get away with a little bit in dentistry, I think we're in that sort of cusping that transitional phase for me, looking at it at a public health point of view, where in another 20, 30 years' time, we might be seeing quite a different kind of public health picture, and one which will require systems and dentists to adapt to. And that brings real opportunities in how we then sort of take things forward. So that I think that's the thing for me that sort of strikes. That's sort of really sort of I've sort of seen in my generation, and the last sort of certainly the last sort of 10, 20 years, and looking at looking at where also the huge demographic bulge in terms of aging demographics. 50% over 20 by 2050 will be over 50% of the population, which is huge shift. So I think interesting times.
Completely agree, Paul. Jan, last word.
I agree. I think there's going to be huge changes in the next few years, and emphasize the issue of a care culture. And I think as well what is clear is that the research community has got to work with not only the policymakers, patients, but also the providers of dental care. That is vitally important to the health of our nations.
Thank you, Jan. Let me just briefly sum up. I noticed we had a question which we didn't really answer that came in via Twitter, I think, from Zoe Marshman, asking about HPV and the role of HPV, and I think that, as I said, is probably for another campfire, and we can maybe come round the fire again to discuss and debate the role of HPV and dentists' role there. Just, I suppose, to summarise what I've heard, and thank you all for your contributions, I think dentists and the dental team, crucially, have a key role in early detection and prevention, and almost a key potential role in broader public health prevention, as we've discussed. I think we need to get there, as Jan and everyone's mentioned, we need to capture that evidence gap, and I think more than evidence gaps, think about implementation, policy change, and all the different human and regulatory and other factors that play into these barriers and facilitators to implementing that kind of change. So I will finish with that and thank everyone. Derek and his cat I saw briefly join us. Al in the room next door in Glasgow, Jan up in Dundee, Paul down in Bangor, and Andre in the background. Thank you all for participating. Cheers.
Thank you.
Bye-bye.
Bye.
Bye-bye.